those who are staying to the end. So why do we risk calculate? We risk calculate to identify for the person, this is your current risk level. But eventually, many people want to fast anyhow. And if this is my risk today, let's say I'm your patient with diabetes, I go to Professor Ilyas, and she would see me and say to me, Mohamed, this is your level of risk. The question is, will that risk, could it be modified or not? So what we have proposed, and if you want to take a picture of this slide, this is really a key slide in the management of diabetes during Ramadan, because we here put 4 steps, 4 important steps for the roadmap for how would you address the person. The first 3 are before Ramadan, and the last one is after Ramadan. So it's quite important that you do what Bashar mentioned, and you risk quantify the person, low, moderate, or high. And then you ask the person or whether they have decided to fast or not to fast. And I'm going to go through a practical demo, and then we'll come to each step through this. So let's assume that you have now Ahmed, 29 years old, type 1 diabetic for 14 years, works as an IT consultant in Dubai, on treatment with glargine 12 units, Novorapid 12 units, and 24 units of glargine. I didn't mention which glargine it is. And his current HbA1c is 8.5. His overall control was slightly higher, and he thought this is due to maybe too much eating out. Like many people in Dubai have the advantage of huge number of nice restaurants, so they go out and maybe overindulge. He'd usually do the SNBG at bedtime to just make the confidence of going to bed safely, but he doesn't really check other times unless he's unwell. Now, he does get frequent hypos about 3 times per week, but he did not get any severe hypos. He feels the hypos coming. He did not have a DKA over the last number of years. He has a normal renal function and no other diabetes-related complications. He is concerned about fasting. He had to break his fast last year for several days, perhaps even a week or so. So I want you to think of every single item written here, because every single item written here relates to the risk quantification, which I need to know. And if I don't have this information, I need to ask about these points, because these will be the recipe. Now, when we make our assessment, technology is key. Technology is key in the risk quantification. You can log on a website, you can print it, you can have it in your own electronic medical records, or you can even for the app. Education is key, and we'll hear from Professor Yaqub about the importance of education. Public awareness. We spend a lot of time educating ourselves. We are already specialists, but the lay person outside, or the social media influencer, doesn't have a medical degree. Glucose monitoring, of course, and we'll hear from Dr. Luqman, and we just heard about some of the technology for insulin delivery. So for electronic medical records, this is a screenshot from our Dubai hospital. In our hospital, when we search for screening, you will get different aspects of screening, and anyone in the hospital who see a person with diabetes can go through the items of the risk calculator. The same is in Tawam Hospital, the same is in Sahha in Abu Dhabi, and it could be simply you give your IT people the Excel and they convert it into something like this, and would be important. Why this is crucial? Because the case scenario that I've just put now, if we don't apply the risk calculator and we start voting, I'm sure there will be some who would say something, some others would be saying something else, and a third group will be saying something else again. But having a standardized approach, that is really quite important. And I was quite delighted when I heard one of the colleagues from Saudi Arabia, trained in Detroit, and his tutor, the American tutor, told him, when he asked about what should I do for this patient. And she said to him, read about the DARC guidelines. So it's reaching people across the globe. So this helps, and you can download it. And today I had the good news that the new risk calculator has been updated. The landing page says still 2021, but is actually the very new one. I'm also maybe share a confidential point. A very important diabetes organization will launch their recommendations of diabetes in general on Monday, and that's in it as well. Not going to say which one, we can all predict. So I here have put the case of the person I've seen. The points in red are the points that he will score. So Ahmed is a type 1, he will score 1. He has diabetes for over 10 years, he scores 0.5. He's on standard basal insulin glargine 100, so he's not maybe on glargine 300, and that scores another 1. He's on short-acting insulin, that scores 0.75. What's green here in this picture is our own modifiable points. All of these points we can modify. I cannot modify his type of diabetes or his duration or his age, but I can modify his type of therapy. His hypoglycemia frequency could be modified. He gets 3 hypoglycemias in a week, so that scores 2 points. His HbA1c also could be modified. Currently, it is above 7.5 and less than 9, and that scores another 0.5. His SMBG is done suboptimally, and again, that could be modified. He doesn't have cardiac or renal problems. He doesn't have new microvascular problems. His job is IT, so it's not physically intensive, and he's not frail or above 70 living alone. He did not receive patient education. So in total, his score is 6.75. And he decided not to fast. Although, if he wanted to fast, we could have worked with him to adjust so many of the aspects which probably would get him into the moderate, and then he has the right. But we have to respect the individual decision. Fasting or not fasting is a personal choice based on number of factors, medical and religious. So we have to think this, be supportive and be helpful. But if he doesn't fast, do we just leave them? We've heard on so many patients that say, I was not given any education because I've decided not to fast. The person who does not fast will equally have the same problems, and we have published a paper on the non-fasting person characteristics. And clearly, they do need, so the consensus of the paper that the non-fasting population demographic and clinical profiles reveal distinctive features, emphasizing that we need to tailor their medication. So we live in Middle Eastern Arab countries. If I'm not fasting, can I eat and drink during the day in public? No. So the risk of hypoglycemia is the same. The potential risk of dehydration is the same. Because I am not fasting when it's iftar time, will I eat a healthy meal or the same vemto and sambusak and whatever? The same. So the hypo and the hyper are the same. So the person, any person with diabetes need to have education regardless of whether they are fasting or not fasting. And I'm delighted that we have the education on our app currently in 4 different languages, in Arabic, in English, in French, and in Urdu, and more to come, inshallah, maybe Turkish and other languages. Ramadan is a social event, and the social events doesn't stop for people who are not fasting. So this picture reflects Ramadan atmosphere in many countries, not necessarily in all countries, but in many countries. So we have to try to help the person. So this is a case of type 1, and the person scored very high. He did not want to fast, and we supported him. Okay, it's your choice. We respect your decision, and we give him a plan on how can we get Ramadan better and glycemic control in general better, whether he's fasting or not. Let me go through another case quickly to demonstrate another scenario. So here is a teacher, a female teacher of mid-40s, with type 2 diabetes for 13 years, and she comes to you now. December, Ramadan is mid-February, so kind of 8-10 weeks or so. HbA1c, she's already on glibenclamide, 15 milligrams, metformin, 1500 milligrams, pioglitazone, and NPH 18 units that was started recently because her control was a bit poor and she was put on NPH. I didn't mention which country, but we have many people on low and middle income countries, and the option of GLP-1s are not available for the vast majority of the globe. Now, since being on insulin, the fact she's also on glibenclamide, she gets hypo about twice weekly when she's busy, which is compounded with the fact that she only checks when she feels unwell, when she feels the hypo. She had retinal examination, was normal, renal and cardiac function are normal, but she has painful neuropathy for the last year. And she wished to fast. But she's a bit concerned because this is her first year being on insulin. So, we go through the risk calculator. She's type 2, scores 0. 10 to 20 years, scores half. She's on NPH, scores 1. Glibenclamide, 0.75. 1 to 2 episodes of hypoglycemia, scores 1. HbA1c being high, scores 0.5. SMBG done suboptimally, scores 1. She has microvascular complications in the form of neuropathy, scores 1. So, on face value, she's a type 2 just on NPH. But eventually her score came to be exactly the same as the person with type 1 diabetes. And we think type 2 diabetes is easy, is the mild diabetes. But for so many reasons, it's not really. But many of her problems are also modifiable. And I have put here together the points that she scored that we can change. The gray I cannot change, but the green I can change. So giving her the education, addressing the modifiable risk factors in the way that you will know and you will see tomorrow and for the rest of the conference of how could this be modified. The trial fast. The trial fast is like the mock exam. We all have been through many exams, and we always do a mock exam before we go to the exam. So fasting for 3 consecutive days give the person with diabetes as well as give us a bit of ammunition to have a better formal assessment. And then obviously we need to personalize her treatment. Unfortunately, we overeat. Ramadan is meant to be the month of fasting, and the hadith and the Rasul Sallallahu Alaihi Wasallam is a third for your stomach, a third for food, a third for drinks, and a third to breathe. Unfortunately, in Ramadan, we fill it up for 9/3, not 3/3. But it's important to know what to eat, not just about the quantity, but about the quality. And you've heard Professor Shaltut this morning or earlier this afternoon showing the hyperglycemia, the correlation of this. So perhaps this lady who wants to fast, the passion for fasting could be the carrot. Okay, let's adjust your medication, let's adjust your lifestyle, let's do more mentoring, and that could lead to not just, say, fasting, but to better overall diabetes control. I put the medication into color code. Green is what we know have very little problems in fasting. Yellow, some yes, some no, and obviously insulin is a bit higher. And we'll hear very soon about the timing, the frequency, and the need and the importance of blood glucose monitoring. And the trial fast, as I mentioned, is really quite important because it can help the person as well as help us. But I think to modify the risk factors and to get the person for safe fasting, it's really important that we are active in public awareness. The person will sit on their Instagram or Facebook and listen to mavericks, and we as experts, we are shy and we don't say what needs to be said. And that's really quite important. Finally, after Ramadan, a very important step to know what happened. How can we make your time better? And how can we make future Ramadans better, as well as your overall control better? So I was spot on time. Thank you very much. And I stop here.